Hello, everyone, and welcome to today's webinar. My name is Abby Klosterboer, and I'm a registered dietitian and medical affairs manager at Nestle Health Science. I'm very excited to be moderating today's event titled Addressing Malnutrition in Patients with Diabetes Across Care Settings. Financial support for this presentation was provided by Nestle Health Science. The views expressed are those of the presenter and do not necessarily represent Nestle's views. The material is accurate as of the date it was presented and is for educational purposes only and is not intended as a substitute for medical advice. With that, I'm very pleased to introduce today's speaker, Dr. Rosa Burgos-Pelaez. Dr. Burgos is an endocrinologist who has specialized in clinical nutrition for over 20 years. She holds a degree in medicine from the Autonomous University of Barcelona, a master's in clinical management of care units from Menendez-Pelayo International University, and a doctorate in comprehensive care and health service from the University of Vic, Central University of Catalonia. Dr. Burgos has been the Nutritional Support Unit Coordinator at the University Hospital Vall d'Hebron in Barcelona, Spain for the past 10 years. Dr. Burgos's areas of interest are in the field of disease-related malnutrition in both the hospital and community setting, as well as specialized nutritional support in specific pathologies, including cystic fibrosis, metabolic disorders, and intestinal failure. She's the leader of the ESPN Guidelines on Nutritional Support in Neurology, a member of the ESPN Educational and Clinical Practice Committee, and has served as the Secretary General of the Spanish Society of Parenteral and Enteral Nutrition for the last 7 years. We are delighted to have Dr. Burgos here to share her expertise with us today. Welcome, Dr. Burgos.
Thank you very much for your kind presentation, Abby, and thank you all the attendants to this webinar. First of all, I would like to thank the Nestle Nutrition Institute to give me the opportunity to share with you this topic, addressing malnutrition in patients with diabetes across the care settings. I'm sure this presentation will be a perfect opportunity to share knowledge and to discuss this relevant topic. These are my disclosures. And these are the objectives of this lecture: to review the prevalence and impact of malnutrition in patients with diabetes, to discuss the nutritional strategies to support patients with diabetes in acute care and transition to post-acute care settings, and to describe the intersectionality of diabetes and COVID-19 and their implications for nutritional support. Let's start with some considerations about the magnitude of diabetes worldwide. In all the continents, we can find a huge number of people with diabetes, and the prediction for the next 10 and 20 years is increasing in all countries, especially in developing countries, with increase in 2 and almost 3-fold times. Worldwide, 463 million people live with diabetes. That represents 9% of the adult population in the world. In the near future, this prevalence will increase and increase. This is dramatic, as the number of deaths resulting from diabetes and its complications was estimated like more than 4 million in 2019. Also, the cost for our health system is astronomical. The implications affect all age ranges. For adults, that we have to know that 1 in 2 can be undiagnosed. For all people, for pregnant women, for children, and also for adolescents. Overall, the direct cost of diabetes is very high, especially for high-income countries. We need to know that the cost of treating complications account for over 50% of the direct health cost of diabetes. And more difficult to count, the indirect cost due to premature death, to disability, and other health complications due to diabetes. And also, we need to consider the intangible cost related with the potential impact in quality of life. With regard to the prevalence of diabetes in the community, these are data from my country. We have a large population-based study representative of the Spanish population, and we have found that almost 30% of the study population have some glucose intolerance, 30% diabetes, 9% glucose intolerance, 3% impaired fasting glucose, and 2.2% both impaired fasting glucose and glucose intolerance. The total prevalence of diabetes mellitus adjusted for age and gender was 30.8%. Of this, almost half did not know that they have the disease. Among US population, recent data are in the same way that in Spain, 10.5% of US population had diabetes. This represents 13% of the adults. But if we consider the undiagnosed patients, the prevalence increases. And if we consider all people, the prevalence is more than 1 in 4 patients suffering from diabetes. In the hospital setting, we need to know that we have to face with a circumstance that produces an hyperglycemic effect. That is the stress related with the disease. The stress due to the disease through the hypothalamus-hypophysis axis initiates a hormonal response that involves both cortisol, catecholamines, and finally acts in the liver, increases the glycogenolysis and gluconeogenesis, thus generating hyperglycemia or worsening of a previous diabetes. The result of this metabolic derangement is represented in the right figure. In hospital, we can find people with previously known diabetes. Also, people with unknown diabetes that are diagnosed during the stay in hospital. And also a considerable number of patients with hospital-related hyperglycemia. In this category, some patients will not recover the normal glucose metabolism and will remain diabetic at discharge. Then, in total, how many have diabetes in hospital? This is a cross-sectional study to determine the prevalence of diabetes in a university hospital in Spain and show that more than 21% of patients admitted in the hospital have diabetes. This represents 1 in 5 patients admitted in hospital with diabetes. And in US, the prevalence of diabetes in hospitalized patients are even higher and account for 1 in 4 patients admitted in the hospital. In this study, only non-maternal stays has been considered. And the most worrying of these statistics is that hyperglycemia is clearly associated with increased mortality, especially in type 2 diabetic patients. The main diagnosis or the main cause for hospitalization are infectious diseases followed by renal failure. And what about disease-related malnutrition? This is another epidemic or even pandemic problem in our hospitals. This is a summary of studies of prevalence of disease-related malnutrition in hospitals in different countries over the world. As you can see, the majority of the studies show a prevalence between 30 and 50% of hospitalized patients. And this is really worrying, especially because this prevalence remains unchanged from the last 20 to 40 years. And this is the reflection of the lack of national strategies to fight against malnutrition. Disease-related malnutrition can affect not only hospitalized people, 1 in 4 or 1 in 3 in cancer patients, but also patients in care homes or even older people living in the community. And the problem is that malnutrition is associated with higher complication rate, longer hospital stays, and increased mortality. Obviously, the cost related to malnutrition is 2 to 3 times higher than for normal nourished patients. What we need to tackle malnutrition? We need to screen and evaluate patients at risk for malnutrition. We need also a plan a nutritional care following clinical guidelines, and multidisciplinary teams including dietitians. The direct consequences of malnutrition are well known: increasing morbidity, worse bone healing, more infections and complications, all of them related with the increase in length of stay in hospital, more need for treatments, and higher mortality, redundant in more health costs and less quality of life for malnourished patients. How do diabetes and malnutrition interact? Chronic inflammation state due to diabetes underlies the pathogenesis of malnutrition, and this is a well-recognized form of disease-related malnutrition, the chronic disease-related malnutrition with inflammation. To assess the prevalence of malnutrition in hospitalized patients, the aim of this Spanish study, the PREDICES study, that is the acronym of Prevalence of Hospital Malnutrition and Associated Costs in Spain. The study was a nationwide, cross-sectional and observational study involving more than 1,500 people. In this study represented the sub-study including only diabetic patients. And we can see that the prevalence of malnutrition in older people with diabetes is more than 40%. Malnutrition is also more prevalent in diabetic women and in emergency admissions. We have also studied the prevalence of malnutrition in hospitalized elderly patients with diabetes. In the VIDA study, it's a multicentric, cross-sectional, and with a follow-up for 8 years. Using the mini-nutritional assessment tool, the risk of malnutrition in elderly patients with diabetes is almost 40%. But using the GLIM criteria to diagnose malnutrition, more than half of patients are malnourished. The consequences of malnutrition in this cohort of patients with diabetes are longer hospital stay, higher mortality, greater need for a convalescent center upon discharge from hospital, and higher healthcare costs. But we can't ignore that patients with diabetes often are multimorbid patients, and it's frequent that concomitant pathologies can interact, increasing the complexity of the healthcare needs. In this slide, you can see the main diseases that affect the chronic complex patients in Catalonia in Spain. Diabetes is the main pathology that accounts for complexity, followed by heart failure, kidney failure, cancer, COPD, stroke, and ischemic heart disease and dementia. That means that nutritional management should be adapted to these multimorbid conditions. Considering the attention to patients with diabetes and malnutrition in the community, often with multimorbid and complexity, we need to favor a continuum between healthcare settings. What are our challenges in the treatment of malnourished patients with diabetes? The first, the difficulty in glycemic control, especially due to insulin resistance. Insulin resistance can be previous to the hospital admission, for example, in obese patients, but is also increased due to the effect of acute response to the disease mediated by cytokines and the adrenal system. The second is the high glycemic variability that is related with bad outcome. The third, we need to avoid hypoglycemia. This is very important for the patient's security. The fourth, we need to think that diabetes is not only a problem with the management of glycemia, and lipid status is also a matter of concern. And the last, gastrointestinal complications can have a relevant impact on glycemic control, mainly with gastroparesis, diarrhea, etc. In order to overcome these challenges, diabetic-specific formulas has been designed. These formulas contains a reduced content of carbohydrates, about 35 to 40%, and these carbohydrates are modified to slow the digestion and the absorption of glucose. With regard to fat content, the diabetic-specific formulas have higher fat content than standard formulas, but these lipids are mostly monounsaturated fatty acids. Diabetic-specific formulas contains always fiber, especially soluble fiber, that has also a favorable effect on glycemic control. In summary, there are defined formulas to control blood glucose, which can help to improve glycemic control and to reduce the patient's need for additional insulin. I would like to share with you this evidence-based recommendation and expert consensus on enteral nutrition in the adult patients with diabetes mellitus or hyperglycemia. This consensus was developed by a group of Spanish endocrinologists and reflect our position statement. Here you can read a summary of the main recommendations. The first, to apply the same goals of metabolic control as applied for all patients with diabetes. The second is related with energy requirements. Energy requirements in patients with diabetes are the same to that of patients without diabetes and with the same clinical conditions. The percentage of macronutrients, and especially the protein content, should be determined on an individualized manner. Recommendations 4 to 7 are related with diabetic-specific formulas, especially recommended for ICU patients or also in-home parenteral nutrition. And finally, recommendation about insulin therapy for hospitalized diabetic patients and for the use of post-pyloric access in patients with diabetic gastroparesis. With regard to diabetic-specific formulas, high in monounsaturated fatty acid, a recent meta-analysis has provided evidence for a better glycemic control measured with the change in glycated hemoglobin from baseline to the improvement of glucose variability and a trend to less insulin necessity and a higher high-density lipoprotein. For the use in community setting, this is also a Spanish study focused in elderly patients with diabetes and malnutrition, all receiving an oral nutritional supplementation with a high-calorie, high-protein formula for 1 year. Not only metabolic control was good, but also the hospitalization and the need for emergency service was lower than the year before. The cost due to hospitalization was decreased more than 60%. And COVID-19 arrived and was like a tsunami for most of us in all the continents, in all countries. COVID pandemic has generated the major scientific evidence in a record time, and some of this evidence is related with diabetes. The initial studies found increased severity of COVID infection in patients with diabetes. And in the other side, COVID infection predisposed patients to hyperglycemia, even in non-diabetic patients. The link between hyperglycemia and COVID infection is the immune and inflammatory response, and this is bidirectional. And this stormy relationship justifies the worst outcome observed in all these studies and with patients in which patients with diabetes had a severe clinical course and even twofold mortality than patients without diabetes. The prevalence of malnutrition in patients with COVID infection hospitalized in non-ICU setting is more than 40% of patients, greater than prevalence observed in previous studies of hospital malnutrition. But in patients admitted from ICU, the prevalence increases to 67%. As a marker, low albumin levels at admission can predict a more severe outcome of the disease. That means transfer to ICU, and even mortality. The type of malnutrition related with COVID infection is also related with inflammation, but in this case with an acute disease or injury-related malnutrition. And what happens when diabetes coexists with COVID? The outcome of diabetic patients with COVID are in relationship with the cytokines and reactants of acute phase related due to infection. Cytokines and other mediators are in the cause of insulin resistance and hyperglycemia, but also in acute lung damage, in vascular endothelial damage, and changes in blood viscosity, promoting cardiovascular events and thrombosis phenomena. At present, we also know that COVID virus can produce a direct beta cell damage that, working together with the cytokine storm, both produce the hyperglycemia at admission, the worsening of metabolic control in patients with diabetes, and even can induce new onset diabetes. But additionally, patients with diabetes have a lot of health conditions that are also implied in the poor outcome: obesity, inflammatory status, procoagulation status, acute complications of diabetes, older age, hypertension, cardiovascular or renal disease. This is a summary of the ESPEN statements and practical guidelines for nutritional management of patients with COVID infection. For all patients, the first step is to check for malnutrition. In non-critically ill patients, dietetic counseling and oral nutritional supplementation are advised, and enteral nutrition in cases whose nutritional requirements cannot be met by the oral route. For intubated critically ill patients, medical nutrition therapy should be tailored depending on gastrointestinal motility and enteral nutrition tolerance. Enteral nutrition is the preferred route of feeding, and parenteral nutrition only if enteral nutrition is not tolerated or is not sufficient. What are the glycemic targets in hospitalized people? The glycemic goals for adults, following the American Diabetes Association statement, are to maintain preprandial capillary plasma glucose between 84 to 130 and postprandial plasma glucose lower than 180. Insulin therapy should be initiated if persistent hyperglycemia over 180 is present, and once insulin is started, a target glucose ranges between 140 and 80. With regard to energy requirements, ESPEN guidelines advise to prescribe an isocaloric high-protein diet for obese patients guided by indirect calorimetry, and to plan energy requirements, protein requirements guided by urinary nitrogen losses or lean body mass determination. If indirect calorimetry is not available, energy intake can be based on adjusted body weight. If urinary nitrogen losses of lean body mass determination are not available, protein intake can be 1.3 grams per kilo of adjusted body weight per day. Most of type 2 diabetic patients are also obese patients. In non-critically ill patients, in the left of the slide, the protein requirements are set in more than 1 protein per kilo of adjusted body weight per day, and energy requirements in 25 kilocal per kilo of adjusted body weight a day. But for critically ill patients, the guidelines advise for first define the nutritional target and to approach the nutritional treatment in 2 phases. The first week, initiate with a progressive caloric growth up to 20 kilocal per kilo of adjusted body weight per day and 1.3 grams of proteins per kilo also adjusted for body weight and day. Once the first week passed, we have to adjust energy requirements to 25 kilocarb per kilo per day. Once the hospital discharge is possible, we need to reassess the nutritional risk and to plan the nutritional treatment with dietetic counseling and oral nutritional supplements if needed. Here are some highlights of the expert statement of this guideline. The first is that improvement of hyperglycemia potentially improve outcomes in COVID patients. The second, diabetic-specific formulas may be considered for enteral nutrition in patients with obesity and hyperglycemia. The third, polyunsaturated fatty acids have well-recognized action on inflammation and coagulation. Then higher intake of omega-3 might be suggested. And the last, very important, we need urgently randomized control trials to identify the optimal formula composition to control blood glucose and to improve outcomes. And we need to avoid some biases that we have found in the literature, in which diabetes is often an exclusion criteria. For example, this is a large intervention study aimed to evaluate the outcome of malnourished, older, hospitalized patients treated with oral nutritional supplements. 30% of patients assessed for eligibility had diabetes mellitus, and thus they were excluded from the study, while the prevalence of diabetes and malnutrition in older and hospitalized adults is very high. This is a nonsense point of view. This is my take-home messages. Diabetes prevalence is increasing worldwide. Prevalence of diabetes in both hospital and community setting is also high, often in the context of multimorbidity. Patients with diabetes are at risk of malnutrition, and nutritional screening should be advised. Malnourished patients with diabetes need a complete nutritional assessment plan to plan nutritional intervention. Nutritional treatment should include metabolic considerations. The use of diabetes-specific enteral nutritional formula should be considered, both for oral nutritional supplement and enteral nutrition. COVID-19 infection is a severe infection with a worse outcome in patients with diabetes. Inflammation and procoagulation state are the nexus for this bad outcome. Medical nutrition treatment is essential to the treatment of patients with diabetes infected by COVID-19. Diabetic-specific formulas should be considered in these cases. Thank you very much for your attention.
Thank you, Dr. Burgos, for that presentation. We'll get started with the Q&A session here. We have a fair amount of time here remaining, so we'll try to address as many questions as we can. To get us started, I think we hear a lot about the high prevalence of malnutrition, certainly in hospitalized patients, and also the high rates of diabetes in the general population, but we don't always hear about those two things together. And to your point, Dr. Burgos, perhaps some of that is the lack of research on this particular topic. I'm also interested, and this gets to our first question. We know malnutrition is often underdiagnosed or underrecognized in general, but do you think this is even more common for patients with diabetes? And what are the potential consequences of this?
Thank you, Abby, for your kind question, and thank you all of the attendants to be connected. This question is very relevant because the recognition of malnutrition in diabetic patients is a matter of concern, because it's true that can be masked by obesity. Even patients can identify any form of weight loss as something positive. Then they can underestimate the involuntary weight loss that must always alert us because can be a symptom of malnutrition. For professionals, we need to distinguish involuntary weight loss and planned weight loss using a defined strategy, dietetic, exercise, both better. And voluntary weight loss is a malnutrition criteria in most of the nutritional screening methods. Then we need to identify it and we need to measure the percentage of previous weight to establish the severity of malnutrition. The consequences of disease-related malnutrition are well known and are related with the increase of complications and their severity, the impaired bone healing, the longer stay in hospital, and even higher mortality.
Great, thank you. Yeah, definitely highlights the importance of identifying and looking for those signs in these patients. So considering I'm on the topic of obesity, because this does often coexist with diabetes, is sarcopenic obesity a concern in patients with diabetes? And how do you approach identifying and treating this from a nutritional standpoint or otherwise?
In the last years, clear diagnostic criteria have been published for identifying sarcopenia. We need to demonstrate both loss of muscle mass and loss of muscle function. Muscle mass function can be evaluated with simple methods as hand grip strength or other functional tests like chair stand test. But to evaluate muscle mass, we need a standardized method. The gold standard is DEXA or CT scan, but other more simple methods can be used as bioelectrical impedance. But in obese patients, a vicious circle is present in which insulin resistance can induce more anabolic resistance and inflammatory changes that promotes a loss of muscle mass. To stop this vicious cycle, it's very important to promote an improvement in insulin resistance. We need to improve overweight, to decrease overweight or obesity with a combined approach. Dietetic and lifestyle habits, mainly exercise, is imprescindible.
Great. Okay, and this is, I think, somewhat related, but how do you approach diabetes management in patients with obesity, and particularly those with BMI over, say, 35 or 40? Is this any different than what you've discussed?
The management of diabetes in patients with morbid obesity is a challenge, is a real challenge. And we need to plan a nutritional but also a diabetological approach. Obesity is directly implicated in the pathogenesis of type 2 diabetes, and the approach should be mandatory in the context of diabetes care. Often, morbidly obese patients have multiple chronic conditions, dyslipidemia, hypertension, sleep apnea. Mostly of them can improve with a weight loss strategy. For the management of diabetes, we need the first to identify some glucose-lowering agents that are related with weight gain. The most used are sulfonylureas and also insulin. Obviously, if patient is a type 1 diabetic patient, insulin treatment is mandatory. But with regard to type 2 diabetic patients, we need to prioritize other glucose-lowering treatments that not only are effective, but also can help to weight loss. Metformin, GLP-1 receptor agonist, for example, liraglutide, DPP-4 inhibitors, for example, sitagliptin, and also sodium glucose cotransporter 2 inhibitors, that, for example, is empagliflozin. And with regard to diet to promote weight loss, we have yet a great debate with regard to the optimal composition of diet to promote weight loss, low carb or low fat diet. Probably the most important of this dietetic plan is to achieve a good energy deficit combining diet, physical activity, and behavioral strategies. Bariatric surgery should be seriously considered in adults with BMI over 35 and type 2 diabetes with associated or without associated comorbidities that are difficult to control with lifestyle modifications and pharmacological therapy. Bariatric surgery can achieve near or complete normalization of glycemia 2 years following surgery, but in some cases the improvement is immediately after surgery, even before weight loss can be acted.
Great, thank you. Very lots of different approaches there, and certainly a complex patient. Since you did speak to kind of some of the diet approaches, in the US, we are seeing more patients with diabetes following very low carbohydrate diets or ketogenic diets, or practicing intermittent fasting, whether it's for, managing diabetes itself or weight loss. So have you seen or would you expect any differences in malnutrition based on these different diet patterns?
In these cases, we need to differentiate the diet the patient is following. Low calories and low carb diet can be a reasonable approach for patients with diabetes, with overweight or obesity, especially in patients if patients are under glucose lowering therapy other than insulin or insulin secretagogues. But in my opinion, we have to advise patients against very, very low carb diets or extremely low carb diets as ketogenic diets. We don't have enough data about safety and efficacy in the long term. The main concern about safety is the risk of severe hypoglycemia, but in the long term, the use of high-fat diet in patients with high cardiovascular risk is not recommended. With regard to the efficacy, we have not enough data because it's a very difficult to maintain diet. About intermittent fasting, people with diabetes may be at risk of hypoglycemia and hyperglycemia, and we know that this glycemic variability is related with a worse outcome, not only the mean glycemic control. Probably we can adapt the glucose lowering therapy if short-term fasting is planned, but we have to advise against long-term fasting, like 1 day a week or alternate day fasting. With long-term intermittent fasting, one concern is about protein malnutrition if patients are not consequent to maintain adequate protein intake on those days when they are eating. Vitamin and mineral malnutrition could also occur depending on how many days a week the patient is fasting and what they are eating. Probably patients can necessitate taking vitamin or mineral supplements.
Great, thank you. So speaking, I think you got on the topic of protein a little bit there. So one question was around if you provide additional protein foods to patients with diabetes, does this or how does this affect their blood sugar?
Protein needs in people with diabetes are not different from those in general population, but we need to know that sarcopenia is more frequent in obese people and is also worsened by both physical inactivity and for the impact of acute diseases. In these cases, in acute diseases, anabolic resistance and accelerated loss of muscle mass have a devastating effect. Anabolic resistance is the reduced stimulation of muscle protein synthesis due to a given dose of protein or amino acids and contributes to decline in skeletal muscle mass. Anabolic resistance and insulin resistant and systemic inflammatory are frequent in obese diabetic patients, especially in older patients. The management should include exercise, but also high protein diet, and probably more than 1.2 proteins per kilo per day, distributed into 3 to 4 protein boluses are a good advice.
Great. Thank you very much. And I think, the topic that often comes along with protein and protein needs and diabetes is around kidney disease and renal function, and whether, are higher protein diets good or bad, and kind of at what stage. So do you have any thoughts on what is the best way to kind of manage a patient with diabetes? And this question was specific to GFR 30, but maybe more generally, patients with diabetes and kidney disease, and how does that affect protein in particular?
The considerations about dietetic management in kidney failure have changed about the last years, and especially during the last year. The main changes are related with the recognition of kidney failure as clear factor promoting malnutrition, and also by the recognition that protein prescription should not be reduced in order to avoid or to delay the kidney replacement therapy in patients with kidney failure. The cause of protein energy wasting in chronic kidney disease patients is multifactorial, but reduced protein and energy intake is the most important. Other factors like hypercatabolism, metabolic acidosis, reduced physical activity, comorbidities, and also lifestyle factors, and also dialytic treatment are also involved in this complex malnutrition wasting, protein energy wasting. But with regard to protein requirements, the recent published this year HESPEN guidelines led by Enrico Fiaccadori established that severe protein restrictions are not needed and can be deleterious for hospitalized patients with acute or chronic disease, and recommend 1.2 to 1.3 grams of proteins per kilo per day in patients that are not under kidney replacement therapy. In critically ill patients, in patients with kidney renal replacement, the protein requirements can be as high of 1.5 to 1.7 even. In critically ill patients, the recommendation is to guide protein prescription to the catabolic rate rather than related with body weight. And this is a novelty in the treatment of kidney disease patients. One important question is what weight should be considered. Ideally, we need to consider the usual weight of this patient or the weight previous to the cause of admission in hospital, not the actual body weight, because it can be modified by edemas.
Great, thank you. Lots to consider there and lots to keep track of. One other question here. So this one is about micronutrients. So do you see any micronutrient deficiencies that are perhaps more common in your patients with diabetes, and how do you address these?
Yes, diabetic patients are not more prone to have micronutrient deficiencies than general population, and we need to supplement these micronutrients only in case of deficiency. But this is an important issue because some micronutrients can be prescribed for patients with the aim to improve glucose metabolism. This is the case for chromium, for example. A chromium deficiency may lead to hyperglycemia, but we only need a chromium supplementation in case of deficiency that is very, very rare. Chromium should be contraindicated in case of kidney disease. Vitamin E, other circumstances, vitamin E, for example, can interact with anticoagulants like warfarin, and thus should be prescribed with caution to diabetic patients under this treatment. For example, vitamin D should not be supplemented by routine and only if deficit can be identified. The only micronutrient directly related with diabetes is deficiency of vitamin B12 in patients taking metformin for type 2 diabetes. This possibility need to be suspected in case, for example, of anemia, and should be monitored regularly over time.
Thank you. So we had a question come in, and this was related to, I think, some of the statistics shown on the slide around prevalence of diabetes in the hospital. So the question is around, can you explain or maybe hypothesize why hospital mortality is twice as high in type 2 diabetes as compared to type 1 diabetes? Any thoughts on that?
Yes, in hospital population, diabetic patients are older and often with more comorbidities with type 2, type 1 diabetic patients. The comorbidities of type 2 diabetic older patients are often related with cardiovascular diseases, renal diseases, and this is probably the cause that mortality in this group of patients is higher than in type 1 diabetic patients.
Okay, thank you. Yeah, that makes sense. So speaking of comorbidities, on that topic, what have you seen in terms of which comorbidities have the greatest impact on nutritional status in patients with diabetes, and how would you approach this?
The comorbidities that have the greatest impact on nutritional status in patients with diabetes probably are two. The first, gastrointestinal complications, such as gastroparesis or diabetic enteropathy. These complications produce a dietetic intolerance and an extremely high difficulty in glycemic control in case of gastroparesis, or an increase in nutrient losses in case of diabetic enteropathy. The approach of these complications should be performed in coordination with gastroenterologists. Prokinetic drugs can improve gastric emptying and gastric tolerance, and a low-fat diet should be advised because the known effect on gastric emptying of fat. The second comorbidity probably is kidney failure. Detecting management of kidney failure without kidney replacement therapy is very, very difficult due to both the effects of uremia on appetite and also the effect of uremia on digestive symptoms. The approach of this complex situation needs to be a tailored plan performed by an expert dietitian to improve energy and protein intake. In these cases, oral nutritional supplements plays an important role in this phase of kidney disease. After kidney replacement therapy is initiated, the diet can be optimized and probably is more easy to follow for patients.
Great, thank you very much. I think we've got time for about one more question here. So I'll end on this one. So are there any other particular patient populations where you would consider use of a diabetes-specific formula, outside of just a diabetes diagnosis?
Yes, we are using diabetic-specific formulas in patients that can benefit of carbohydrates complexity, and also patients who can benefit for this predominance in soluble fiber. For example, we are using diabetic formulas for patients with digestive problems, especially when diarrhea is present. in some cases, diabetes-specific formula can prevent the need of oligomeric formulas, which are very less palatable formulas. In oncologic patients, we are not using diabetic-specific formulas unless we suspect insulin resistance or in cases with corticosteroid-induced hyperglycemia.
Great. Thank you so much. All right. Well, that was wonderful, Dr. Burgos. Thank you again for sharing your expertise, and thanks to our audience for your attendance and engagement. On behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice. Please take care and enjoy the rest of your day.